shuffled the just very quickly, I will repeat myself. Please mute your microphones and use the chat function for any questions. And we will start with Joe Allen as our first speaker. So Joe, please, the floor is yours. And if you could just introduce yourself briefly.
Sure, thanks for inviting me. And just a reminder, if you can remind me on the time so I know to hit my target. What time do you want me to hit before question and answer?
25 minutes.
Okay, hi everybody. Joe Allen, I'm a professor at Harvard's T.H. Chan School of Public Health, where I direct the Healthy Buildings program. Background and expertise is in exposure and risk science. And so I'm a certified industrial hygienist. If you're not familiar, that's the field that really looks at how do you protect workers. Think about anticipating, recognizing, assessing, and controlling hazards in the workplace. So I'm going to share my slides today. I'll be talking about healthy buildings, particularly in the role of COVID-19, infectious disease risk reduction, and a little bit of a broader lens on why healthy buildings matter and should be central to our approach here. And just really looking forward to the question and answer period too, so we can take this wherever you think will be most useful. So I want to be clear that we've been talking about the role and power of buildings to advance health for all, including during a pandemic. So this was written, a colleague and I wrote this for Journal of Exposure Science and Environmental Epi back in December of 2019. It was never a question of if a pandemic would hit, it was always when, right? We narrowly missed other coronavirus pandemics in this century. And so we didn't know what was around the corner for the world, but we certainly knew that whenever something hit, buildings would play a key role. Why? Well, we have a lot of evidence that buildings either can protect us from infectious disease or aid in the spread. We had outbreaks going back to measles outbreaks 40 years ago in schools. We had outbreaks from the first SARS, where one person in a hotel room actually seeded the global outbreak. And it's again gets down to the basics. Now, this is an article I wrote in the New York Times last March. I wrote a piece in Financial Times in early February 2020, talking about buildings as the first line of defense, and talking about hopefully a lot of things we're going to talk about today, but you know already at this point or have heard. We need better ventilation, better filtration, use of portable air cleaners, potentially the use of upper room or ultraviolet germicidal irradiation. So basic tools that we have at our disposal to help. But before we can recognize or appreciate that buildings play a key role, we have to understand why. And here it gets really important because the world has been quite honestly behind on the recognition that SARS-CoV-2, the viruses that cause COVID-19, is transmitted through the air. So for the whole past year, if you looked at WHO guidance and the US Centers for Disease Control guidance has focused on two modes of transmission: droplet, close contact droplets, meaning large ballistic droplets, and fomites. Fomites, just a contaminated surface, and ignoring airborne transmission or fine aerosol transmission. So I want to present some of the scientific evidence for why this matters, because that sets up why buildings matter. So if we don't start from this point, then nothing else, then it doesn't make sense for ventilation and filtration. So here's what we know about the science of airborne and aerosol transmission. Every time when we're breathing, coughing, singing, talking, saying ah, we're emitting respiratory aerosols or respiratory particles that can carry the virus. The virus is never naked in air. It's always traveling in our respiratory aerosols or drops, some droplets that drop out of the air and others that'll stay aloft. This figure is showing research showing that the particle size range that dominates when we count, breathe, or say ah is in this, under 10 micron range. We emit larger particles. 100 micron range will drop out of the air. And I'm going to tell you why the particle size is so critical. But for now, suffice to say that most of the respiratory particles we generate are less than 10 microns. Counterintuitively, these smaller particles are where the higher viral load is, right? It's not the big droplets that carry more virus. It maybe seem intuitive, but it's incorrect. So we have several studies showing that the virus is largely concentrated in these under 10 micron. Here's where it gets interesting from a risk and exposure reduction or an epi standpoint, is that a 5 micron particle, if you look at this figure and some basic aerosol physics, a 5 micron particle will stay aloft for 30 minutes or more. A smaller particle will stay aloft for hours. In fact, they'll stay aloft until they're removed through ventilation or filtration. So we know basic aerosol physics means these particles don't drop out of the air. And because they don't drop out of the air, they'll travel across any room. So look at the x-axis there, the distances. A 5 micron particle in red there will travel well across any room, as will a 10 micron particle. So most of the particles in virus concentrated in under 10 micron size respiratory particles, they stay aloft for long periods of time and they travel. So we should have known early on to act for this virus and others, quite honestly. The data there were even more compelling going back to last year as an editorial I wrote with Dr. Lindsay Marr on some of this evidence, including we detected viral RNA in hospitals at distances beyond 2 meters or 6 feet in places that could only be reached through the air. That's not viable virus. There's limitations with that kind of sampling, but sure enough, as others will continue to work on this, there were some studies showing that you could detect not only RNA, but viable virus well beyond 6 feet or 2 meters. In this case, in a hospital with, if you look on the right there, that note, high air exchange rate, 6 air changes per hour, and good filtration, a MERV-14 filter. I'll talk about those in a minute. We also have many high-profile outbreaks at this point, showing that airborne transmission is happening. Here's a restaurant in Guangzhou, China, where one person infected many others, including people beyond their own table. And the culprit here was a recirculating air conditioning system. No filtration, wasn't bringing any outdoor air, and it was just circulating the air around this group of people the entire time they were eating. One infector infected several others. We've seen the same thing in hospitals. Here's a hospital outbreak in South Africa. The beds in red are primary infectors, and green are patients they infected. This is an intensive care unit. So there's no direct contact between the patients, and yet we saw this spread happen, likely through airborne spread. Famous choir practice outbreak in the United States, 90% attack rate. One person infected 52 others, 2 died. 52 out of 62, I believe is the number, 61. What was interesting when I first saw this is that if you think about the building dynamics, this rehearsal, choir practice rehearsal, took place in the evening. And what happens in the evening in our buildings? Well, we turn off our ventilation systems, right? We bring the amount of fresh air coming in way down to conserve energy. And usually it's a period of low occupancy. But if you do that and the building's occupied, then we see these super spreader events. Here's my own team's work modeling the outbreak on the Diamond Princess cruise ship. If you look at the figure on the left, the box plots here, we estimate that aerosols, not droplets, aerosols contribute almost 90% of exposure, and droplets playing a much smaller role. If you look at the figure on the right, after quarantine, where we could best characterize their time activity data, we think short range aerosols within 6 feet or 2 meters, about 60%, a little under 60%. Longer range, so beyond 6 feet, within the same room, beyond 2 meters, about 40%. And fomite or surfaces contributing very little contribution. So at this point, we've seen outbreaks happening all over the world that are well characterized. And honestly, it's the same factors every time. Time indoors, no mask, low to no ventilation. And it doesn't really matter if it's a restaurant, a hospital, choir practice. We've seen outbreaks in churches and schools, and gyms, And so it doesn't really matter if those conditions are present. That's what's more important than the actual place. Okay, so I want to talk about, now that we know that airborne spread is definitively happening, how do we control it? So I've been writing a lot about this, and here's something I put together for, or my team and I put together for schools going back to July. And on the right, we've been recommending targeting 4 to 6 air changes per hour. And for reference, typical air change at a US home is about half an air change per hour. Schools in the US, and actually in many parts of the world, designed for about 3 air changes per hour. So not enough for what we need to do to control this virus. And you can achieve this air changes per hour, this effective air changes per hour, in a couple different ways. And we recommend prioritizing in this 1, 2, 3. 1, increase the amount of outdoor air. 2, better filters. You want these MERV 13 or higher filters on the recirculated air. A building typically has what's known as a MERV 8 filter. It captures a relatively small percent of the particle sizes we're interested in. And then last, you can supplement with portable air cleaners with HEPA filters if they're sized correctly for the room. And I'll talk about those in a minute as well. The big picture, 4 to 6 air change per hour. We've had this recommendation out for a long time. One of the key challenges has been that there's many organizations that have made a similar recommendation along with us going back 14 months, bring in more outdoor air. The problem is groups like ASHRAE, CDC in the US, even WHO haven't set a target. So you can imagine, I do a lot of work with different organizations trying to put in controls. We tell them bring in more outdoor air. What's the next question? How much? And so with that 4 to 6 air change per hour target, we've been trying to give some clear guidance to schools and office buildings and everywhere else. And just last week, at a piece published in JAMA, finally broke through to the medical journals with this idea of targeting higher air change per hour. We have a problem in our buildings. We're not bringing enough outdoor air. The current standards are not designed for infection control, and there are no targets being set. So we give an argument in our opinion on why this 4 to 6 air change per hour makes sense in smaller volume places, both for SARS-CoV-2 and provides other benefits to health. So that came out last week if you're interested in that article. And this is why it's such a major problem around the world. Here is the brief history of ventilation standards. I'm not going to go through them all, but I want to just point out a couple things. So on the vertical axis there, we have this, a ventilation rate. The red dotted line is a target that we think the science shows is protective for health and even provides health benefits. Well, about 100 years ago, we used to set our ventilation rates for health. In fact, we used to set them in part focusing on, or large part, focusing on infectious disease transmission. But over the past 100 years, we've really kind of lost our way. We've started to tighten up our buildings, tighten up our building envelopes, big changes in response to the energy crisis in the late 1970s, where we started choking off the air supply in our buildings below health-based benchmarks. So we started prioritizing energy over health. And we're paying for this right now around the world. ASHRAE is the standard setting body for ventilation. It sets a target for minimum indoor air quality. It's not an infectious disease target. And so many buildings now, even once they know airborne transmission is happening, no better ventilation and filtration are necessary, are finding that their buildings were not designed for this. They were designed for low levels of ventilation. That's a problem, and it's one we need to change going forward. I do want to make sure I point out or put this in context, right? Because far-field airborne transmission is not the only route of transmission that's happening. And that means ventilation, there is no one strategy in and of itself that's sufficient. So ventilation isn't the only thing we need. And the way we've been talking about this is to use something we call the hierarchy of controls. So hopefully you've seen this. This is inverted from how it's normally presented. Usually it's an inverted pyramid. But we wrote this for the business community in Harvard Business Review last April, actually, a year ago. And the hierarchy of control has 5 parts, and it's a nice way to make sense of all of the control strategies that need to be put in place and in what prioritization. So, and this works for chemical exposures, works for biological exposures like this virus. So first at the bottom there, you want to eliminate the exposure. Can you eliminate it entirely? That would of course be ideal and the most effective approach. And as you think about returning to schools or offices, the only way to do that is to work from home, but not everyone can do that. And it's certainly not the path. There are severe consequences to having, for example, kids out of school. So then we think about substituting activities. What are the activities that need to be back in person in buildings? Can we add different layers on top of that, like screening, testing? Third, there in the middle is engineering controls. These are healthy building strategies like better ventilation and filtration. Fourth, moving up, administrative controls. This is where physical distancing becomes important and managing people and flows of people inside buildings. And last up top is PPE for personal protective equipment. In the context here, it's mask wearing. So if you do all of these things, we know that it's a layered defense. We put enough defenses on top of each other, we can minimize risk. I thought I would take this in my last few minutes here to talk about what this looks like in schools and maybe some practical guidance on how this works. So this is a presentation I gave to the USA EPA last week, and I'm not going to go through all this graphic here, but we like the school smart idea on how to control it. And actually, it's tied a lot to the hierarchy of controls, just presented differently. So S, stay home when sick. M, mask up. We got to wear our PPE. A, air cleaner in every classroom. So these portable air cleaners can be quite effective. Refresh indoor air. That's better ventilation. And getting outside. We know one of the key risk factors is time indoors. So what does this look like in buildings and thinking about ventilation in particular? Well, we can look at what happens indoors. And this is an article that was published in the New York Times that might be interesting, and it could apply to any space, but showing how our breath, when we just breathe and talk inside buildings, right, mixes with everybody else's. And depending on the level of ventilation, you might be breathing in 3, 4, 5, 6, 7% of air that just came out of someone else's lungs. That's what we call the rebreathed fraction. And in this article, we actually followed the particles that are emitted in a classroom and show what happens, that this spreads throughout over time, right? This is not just a 6-foot distancing or 2-meter problem, any space that's underventilated. And importantly, in this article, we show what happens when you enhance the ventilation, put in portable air cleaners, open up a window, put a fan in the window to improve circulation. You can drive these concentrations way down. But it's a nice interactive visual that I thought I'd share. This is the print edition, but if you search for New York Times ventilation in schools, I think you'll find this interactive graphic. So in terms of the practical standpoint, the how do we assess ventilation in buildings? I thought I'd use this school example. We put out a guide for how to assess ventilation in classrooms. One of the things you can do is just measure it. And here we're using the airflow capture hood, or we call it a bolometer. And here we're measuring the amount of air coming into the school. This is on the other side of that wall, in the picture on the left, is a unit ventilator. And this hood is just measuring how much air is going through that vent. You could take this hood and put it up onto a ceiling if you've seen the diffusers in the ceiling and measure the same thing, how much air is coming out. You can also use tracer gases. On the picture on the left is some dry ice. We intentionally raise the level of CO2 in the space. Then we remove that source and we measure the CO2 concentrations and how quickly they decay or decrease when we have the ventilation system on, or in this case, on the picture on the right, even just opening a couple windows a few inches. When you do that, here's what the data look like, right? You get the CO2 concentration on the y-axis, time on the x-axis, and we can measure this decay. So in this example, the ventilation rate, where we see the CO2 decaying, and just from the unit ventilators on, the mechanical ventilation system, we get about 1.6 air changes per hour. We open the windows, we get about 4 air changes per hour, the slope changes, and open the doors for cross ventilation, we get over 5 air changes per hour. So just from a simple strategy here, we can achieve that 4 to 6 air change per hour target, and here's how we can measure that. We do this in buildings all the time. So outside of schools, here's an example from Harvard. We measured CO2 decay rates in lecture halls. So you'll see, if you look at, let's take the top left figure there, the gray dots, the CO2 concentration builds up during the class. Class leaves, that green line shows decay. Another class comes in a few minutes later, CO2 goes back up, and then we watch the decay. If you measure the decay rates, you can convert them into air changes per hour. And in this case, we can see in that top left figure, first class had about 3.5 air changes per hour, second class had about 5 air changes per hour. So the use of real-time monitoring with CO2 can be really effective. I'm actually monitoring CO2 in my office right now. I'm at 468. So you can use these as a way to either measure steady state CO2 as an estimate of ventilation rate, or look at the decay rates. I want to show you two tools that you could play with and actually look at some of the formulas. So my Healthy Buildings program at Harvard is at forhealth.org, forhealth.org, and we have a page dedicated to schools. And I think I can, well, I don't know if I can show it to you or not. Well, maybe I won't. I'll just let you know this is here, but I want to point out two calculators we built. The first is a calculator that takes the CO, that lets you determine what your air exchange rate is based on the CO2 concentration. So the tool lets you input things that you might expect. Number of people in the room is going to influence CO2. The type of activity they're doing. Are they breathing hard or not? Are they resting? Are they reading? The age of the person in the room. Kids, of course, have lower exhalation rates or respiratory rates. So you do those things and you can actually target an air change per hour rate based on the CO2. And on the bottom, we have another tool on portable air cleaners to help you pick the right size air cleaner. And this is really quite simple to determine how much clean air you're getting from a portable air cleaner. Portable air cleaners report something they call the CADR, a clean air delivery rate. That's in units of CFM, cubic feet per minute. So if you take the clean air delivery rate in CFM, cubic feet per minute, multiply it by 60, that's cubic feet per hour, divide that by the volume of the room. That's the air exchange rate in air changes per hour. So said again, you take the clean air delivery rate times 60 divided by the volume of the room, that's your air exchange rate. And so you could take the size of the room you're in if you wanted to bring in more clean outdoor air, decide you want 4 air changes per hour, and then go pick the device you want based on that device's clean air delivery rate to be sure you're getting the appropriate amount of clean air. Last thing I'll say is that when we think about health in buildings, or let's say health first, health is not just disease avoidance or the absence of disease. We're rightly focused right now on a global pandemic and infectious disease, but health is more than that, right? It's well-being, it's flourishing. And buildings play a central role in all of this. And it's not just air quality. So we're talking a lot about viruses, and the top two here, ventilation and air quality. But there's more to a healthy building. And my team put out a report we call the 9 Foundations of a Healthy Building. You can read it, but we talk about the 40 years of scientific evidence on factors like lighting and views, and biophilic design, acoustical quality, water quality, feeling safe and secure, thermal conditions in the space, and how all of these things influence our health, not just for the absence of disease, but also health promotion. So happy to talk more about that too, or more broadly speaking about healthy buildings. So let me stop there. I'm right at 10:25 here, and happy to participate in a question and answer. Thanks.
So thanks so much, Joe, for that really fascinating talk. And while the questions are coming in on the chat, I thought I would take the opportunity to ask a question about science communication. So early on in the pandemic, there was just a huge demand for practical advice about what to do to protect children in schools, hospitals, workplaces, and it's the exposure science community and epidemiological community responded in varying degrees of success, but your group has really been a leader in terms of science communication on these topics. And I'm just wondering if you could comment a bit on what, in your experience, has worked the best to get this practical information to a broad audience, clearly and quickly.
Yeah, thanks so much. That means a lot. Yeah, I agree. I think the public health community was trying to fill a lot of gaps for the past year in official communication, particularly in the US, where there was misinformation and, quite honestly, disinformation coming out of the prior administration. And let me talk about the challenges here for a second, because we're not always incentivized in academia to do this kind of work. I think in public health maybe, but a lot of grants don't have research translation components to them, or the funding's not there to take it beyond a peer-reviewed paper. But it's critically important. I'll tell you, I even got comments. I'll share this. I haven't shared it before. I got comments early on here. I was writing op-eds. I've written 35, I don't know, in the past year. But someone saying, well, shouldn't he be publishing more peer-reviewed papers? And so I take offense to that, but it tells you this kind of ingrained problem in academia that this research translation is not part of our reward system or what we should be doing. I fundamentally disagree. In terms of what works, yeah, I don't know. We tried to hit on every channel. I mean, we're publishing the peer-reviewed papers, absolutely. We tried reports on our own website. We built these cool little tools. We put out 20 questions every parent should ask about schools. Written op-eds in every outlet I can think of. My team has too. We built calculators for the public. So I don't know what the answer is other than I think hit on every channel, right? We put out things on YouTube. I haven't gone to TikTok yet, but I'm not opposed to it. So I'd be willing to do anything. I think that's our role, is to think about how you can clearly communicate. I think sometimes we get in our space and sometimes we think, oh, everybody knows this, and we just have to get away from some of our language, the overly scientific language. We're scientists, I think that's important, but in order to communicate to the public, we have to be able to explain it in a way that everyone will get and understand. So we've been trying, I don't know, every channel. I'm open to new ideas too. So just trying our best, not quite sure what the answer is.
So there are a few questions here. One question is, how realistic is it to implement smart strategies at every school? And could you comment on the inequity of implementation across school districts, for example, across different income levels?
Yeah, it's a great question. So I'll start on the inequity part. We've known, so first, we've underinvested in, let's say, school buildings for decades across the board. Even more so, we see disparities in terms of things like building infrastructure quality, specifically ventilation and filtration. We see schools in predominantly Black and brown communities having lower rates of ventilation, right? So across the board, all schools are underventilated, even more so in Black and brown schools, or schools that are primarily Black and brown students. Same thing in schools where there are predominantly kids, or higher percentage of kids of low income, as measured through things like percent of students getting free and reduced lunch. So the disparities exist. It's real. I don't think that's a surprise to anybody. In terms of how realistic it is to implement this, I'll say my team and I have been very careful not to make recommendations that are break the bank recommendations. We're not saying put in some fancy new technology. There's lots of that happening. In fact, hundreds of millions of dollars spent on unproven tech. It's a deep concern of mine. But we've been clear, right? The basics here: opening up the windows, higher ventilation rates, putting a better filter on the recirculated air. That's a couple dollars. Portable air cleaners, a little more expensive, but not with the funding that has come out of the stimulus funds in the U.S. Totally reasonable to put a portable air cleaner in every classroom. Is, a couple dollars per student per year, and that could solve this problem. Wear a mask, put these in there. So we've been, we're not saying everyone has to overhaul their whole mechanical system, spend $10 million or anything like this. We're trying to find ways that everybody could do this and can do it relatively quickly. And the money is there for it, at least in the US now with the stimulus funds, even going back to last year. So it's a really important question. My biggest concern is that now that real dollars are flowing for stimulus, that some of it's going to be wasted on things like these unproven technologies, surface cleaning, plexiglass. And it's a once in a generation opportunity where billions of dollars are flowing to schools. And so we have to get it right. I lose sleep over this right now, that this money will just be squandered on unproven approaches when we haven't had the proper funding for school infrastructure for decades.
That's quite sobering. Here's another question asking about the trade-offs between ventilation and energy efficiency or climate change mitigation goals. Maybe you could comment on that.
Yeah, it's a great question. So I think this is one of the key challenges of our time right now, clearly. And I think we can have higher ventilation rates without compromising our energy goals. We need more energy efficient systems. We need to get smarter about how we ventilate our buildings. Right now, we just let's take an office building. We dump in air everywhere, even where people aren't, right? So we need things like demand control ventilation. When people go into a conference room, that's when the air supply hits. We can be a lot smarter, and there are other approaches like underfloor ventilation where you can deliver less air, but the ventilation effectiveness is higher because you're actually bringing more air to the breathing zone. We can decouple thermal conditions from bringing in more outdoor air. Right now, those are coupled, and that's a big problem. So we have to cool and heat our buildings, and it's tied into these higher energy through ventilation. So there's a whole bunch of strategies we're going to have to do, and I'd be remiss if I didn't call out the big one, which is where I'm most hopeful, is we have to clean up our energy grid. So buildings are certainly part of this problem, but if they're pulling off a clean energy grid, well, then it doesn't matter as much, right? So I think it's a bigger problem. I think a bigger problem in buildings right now is the on-site combustion of fossil fuel. This concerns me. I think it's a harder problem to solve in some ways, but the question is spot on, and this is an area that's ripe for really creative solutions in terms of finding this energy health balance. The problem, I'd say, over the past 40 years, though, is that we've chosen energy over health. I don't think that's a good solution either. We can't just, we could have perfectly energy efficient buildings. We seal everything up, great. But then we're creating these sick buildings that we're all spending our entire lives in. So that's not a solution either. There's got to be a balance there. We presented with this false choice. It's energy versus health. And actually we can and have to have both. We just have to be a bit more creative in our solution set here.
No, really interesting. There's another question here about citizen science, whether you had integrated citizen science approaches in any of your COVID work.
Yeah, for sure. So I think almost everything with schools is citizen science. We're not out there doing the work in all the schools. We've done a couple, but then we put out the tools and saying, look, this is, these are things anybody, you can go measure CO2 and ventilation in your school. You look, here's how you go do it. And I'd say the other one that's happening is, I've been showing this on TV when I present and showing, hey, here's the CO2 in my office. When I showed this, I think it was on Don Lemon in November, right? Then these things sold out. People are going around, talk about citizen science, they're measuring CO2 and reporting this stuff on social media. Hey, company X, I've been in your building or on your airplane. Why is it 2,000 parts per million? So talking about citizen scientists leading to some big changes, I think this kind of increasing awareness and let's say the availability of these lower cost tools for the first time lets us kind of make these problems visible where they've largely been invisible, right? But now you can actually show and share the data. Great citizen science work. I mean, thinking about the outdoor air networks that have sprung up with these same kind of sensors. It's one of the ways we understood the spread of wildfire smoke in California last year and this year and going forward. These kind of citizen science sensor networks. I think we'll see some of that move indoors, which is really kind of exciting too.
There's another question about workplaces in low-income countries or settings where more expensive changes might not be so easily achievable, for example, in food industries or meatpacking plants where workers may have to stay quite close to each other. You mentioned the important role of just opening windows and increasing ventilation, which don't have a big cost associated with them. But would you like to comment on what some of the priorities could be in these contexts?
Yeah, we have totally failed our essential workers over the past year all around the world. And here's where I think, right, talking about low cost, low tech solutions, the fact that we have not distributed high quality masks has just been one of the big misses in the pandemic response. So if you think about controls that can work inside of a building, all the controls I'm talking about are important, but source control is the most important. And so right now we've been saying everybody wear a mask, and that means different things for everybody. A cloth mask might be 20% of capture efficiency. But we know if you go up to a KF94 like in Korea, or an N95 in the US, right? That's 95% efficient. You do that universally, you can get to 99% exposure reduction through the use of masks before any distancing, right? 2 filters, even if you have 70% efficient masks, 2 70% efficient masks, the combined efficiency is 91%. That's before distancing and before ventilation filtration, taking care of the space between masks. How have we not provided these cheap masks that are effective, breathable? How have we no advancements in this space? It's cost a few dollars, that's it. And so I think that's been a huge miss. I'm disappointed in the US. A couple of weeks ago, OSHA was supposed to issue an emergency standard. I was hoping it would include more robust measures, including better masking. And that deadline came and went, and they didn't issue it. So I don't know what's happening there, but there's only so much we can do with ventilation and other controls. We should still target them, but if not, or in addition to, better masking one has been a major failing.
So here is a question from Raquel. She's a fan on Twitter. I have to say I am as well. Again, you've just done such a great job on the science communication, including on Twitter. And so the question here is, in Spain, the National Research Council elaborated a guide of ventilation on classes from your guide. And could you please give an opinion about workplaces like offices and indoors where workers are not wearing masks when they are in their workplace, because business owners say that mechanical ventilation is enough and they don't need a mask indoors?
Yes, it's a great question, and I'm glad that the my Twitter feed is useful. I never know how that's being received, but I've tried to put out a lot of information there. So masks should be worn. Let's take the context, right? Assuming countries or areas with high case counts and low rates of vaccination. So I think we're going to move to a place where vaccines change this paradigm. But right now, cases widespread. Yes, masks are needed indoors. Outbreaks happen, time indoors, no mask, low to no ventilation, like I said earlier, right? So ventilation is going to be, and better filtration can tackle far field transmission beyond 6 feet. It's going to have very little impact for close contact. In other words, Raquel, if you and I are talking face to face at 1 meter, ventilation is not going to sweep that air out. Outdoors, sure, you get lots of air movement, lots of airflow, not indoors. So there, masking is absolutely critical. And so I think it's a mistake not to have masking. I have been surprised, and have written in the UK, for example, where they have masking has been not very stringent. And in fact, in schools, they could take their masks off a lot of times. So I think I think they have to be in place. That will change. That will change in countries that become highly vaccinated, because we've seen case counts drop and the risk will change. I do think something like ventilation and filtration should stick around long after COVID. Why? The science has been clear that higher ventilation rates provide protection against other infectious diseases, airborne viruses, and provides benefits beyond infectious disease. My own work and team's work showing benefits on things like better cognitive function, reduced worker absenteeism. So there's lots of other benefits. We've been clearly underventilating our buildings for too long. So as a long answer, short answer is, yeah, masks indoors. Ventilation alone is not sufficient.
And there's, this will take as our last question, is from Juana Maria Delgado. Do we have enough information on the half-life of SARS-CoV-2 to consider both the physical information and its duration in the air and viability to inform remediation measures? I'll leave it there. It's a bit of a complex question.
Yeah.
Juana, I don't know if you can turn on your mic. Maybe you want to clarify the question.
Yeah, I think I got the question. It's a good one, because the question is, right, well, I'll paraphrase it, or try to anyway, right? If the virus isn't viable for that long, then, is there enough time for the mechanics of ventilation filtration to even work? I think it's a really good question. The answer is yes, right? The virus will be viable in air, and the dynamics of ventilation filtration will operate much more quickly on the virus than concerns about it just naturally decaying over time. Now, where that gets interesting, if you have a really large building and your return air goes all the way up, many floors into a central system, gets mixed with other air, gets back delivered. One, you're diluting. There's a longer amount of time, longer pathway for this virus, more dilution happening. We don't see kind of within building transmission through the mechanical system. Right? We see within room transmission. We see plenty of rooms where they recirculate air or have a ventilation system in the room. But we haven't seen, for example, someone on the second floor infecting someone on the third floor, for example, if they share the mechanical system, or even someone across the room, across the floor, pulled up through the mechanical system, brought to a central place and re-delivered. So it's a really good question on the dynamics there and some of the nuance. We can make these broad recommendations and generalizations, but you start to get specific to your specific building, risk level, community spread levels, whether or not masking is in place, how much vaccination is happening. And then it changes these answers. So really, really smart question there.
Well, thanks so much, Joe. We really appreciate you joining us today. And we'll now move on to the next speaker, Rachel Lowe. Rachel, the floor is yours.
Thank you very much. And thank you, Joe, for that fascinating presentation. That was really, really eye-opening. So thanks very much for the invitation to take part in this course. I'm going to be speaking today about the influence of meteorology on COVID-19. Okay, so in this talk, I'm going to cover briefly the potential mechanisms driving seasonality of respiratory viral infections. I'm going to talk about how climate services can potentially support the COVID-19 response. And I'm also going to share with you some of the work we've been doing trying to disentangle the impact of meteorological factors from non-pharmaceutical interventions and other confounding factors such as socioeconomic factors on COVID-19. Just briefly, a bit about my background. I did an undergraduate degree in meteorology and oceanography at the University of East Anglia with a year in Granada in Spain. I then did a master's degree in geophysical hazards, which focused on disaster risk management and thinking about different geophysical hazards such as volcanoes, earthquakes, extreme heat. I then did a PhD in mathematics at the University of Exeter in collaboration with the climate services and Fiocruz in Brazil. And that's when I started to become really interested in how we can use climate information to inform public health decision making. I was particularly focusing on developing early warning systems for dengue. I then did a couple of postdoctoral positions in Italy and Spain, thinking about how we can bring in climate information to strengthen malaria control programs and also dengue in different parts of the world. And that's then I moved to the London School of Hygiene and Tropical Medicine, where I am now, with a Royal Society Dorothy Hodgkin Fellow. And I'm currently leading a group working between the Centre on Climate Change and Planetary Health and the Centre for Mathematical Modelling of Infectious Diseases. So Adrienne asked me to include a slide about my background. So now you know why I'm interested in the impact of climate on infectious diseases. In terms of COVID-19, I'm part of the World Meteorological Organization task team looking at COVID-19 and bringing together the evidence on the potential links between meteorology and air quality factors and the COVID-19 pandemic. So some of you may have had a chance to take a look at the first report that was published last month. So there's been a lot of debate and discussion about whether COVID-19 will be whether it shows any seasonality, any similarities between other seasonal viral infections such as influenza and other human coronaviruses. So we know that these viruses tend to peak in sort of in autumn winter season, particularly in temperate regions. There are lots of proposed mechanisms for this, but it's not entirely well understood. But meteorological factors such as temperature, humidity, and ultraviolet radiation are thought to impact COVID, or are thought to impact respiratory viral infections through the survival of the virus itself. So viruses in laboratory conditions have been shown to survive better in drier and cooler conditions. These factors are also thought to impact human immunity and resistance to these infections. And of course, weather also impacts the way that humans behave and gather indoors, which was very nicely covered in the last presentation. So it's very difficult to understand exactly at which point weather becomes important and whether we can use this to help understand the timing intensity of outbreaks. And of course, weather and air quality are not the only factors that would impact the transmission of the virus. In terms of COVID-19, it was very much influenced by the connectivity to China and other hotspots early on in the pandemic. And then it's very much, transmission is very much tied to personal protection, such as mask wearing, other non-pharmaceutical interventions. Of course, now we're in an era of vaccine campaigns as well. And of course, factors related to living conditions and population density are also very important. So why do we need evidence on the links between weather and COVID-19? Well, early in the pandemic, some politicians, including ex-President Trump, which feels really good to say that, were making claims such that things like, one theory is that the warmer weather will make COVID miraculously go away. And by April, Trump thought that COVID would just die away. And that could have, this kind of sentiment could have led to a lot of complacency earlier on in the pandemic, and certainly there was a lot of misconceptions that we would be safer during warmer months, particularly in the Northern Hemisphere. So we wrote a commentary earlier on last year, and we were showing that local transmission had established itself by the 24th of March in most countries around the globe, and that we could not see any pattern between the temperature and humidity in places where local transmission had been established or not. And by the time we published this piece after acceptance, pretty much every single country had experienced local transmission. So really nowhere was spared from this. And so we incorporated some of this into the Global Heat Health Information Network in their frequently asked questions. And back in May 2020, there was insufficient evidence to suggest that seasonality was playing a role in the transmission of SARS-CoV-2, and that's pretty much still the sentiment today, despite lots of studies looking at the impact of meteorological variables on COVID-19 transmission. There's been many preprint studies and some in the published literature, but they're showing conflicting results, and many studies haven't properly accounted for confounding factors and other important drivers of transmission, such as the government interventions and also socioeconomic disparities. So the overall conclusion of the first report from the World Meteorological Organization task team is that the government interventions outweigh weather factors in determining COVID-19 transmission patterns, and that meteorological and air quality factors should not be used to base decisions about relaxing interventions at present. But there is a role for meteorological and climate services in supporting the COVID-19 response, particularly in terms of extreme weather advisories. So the impact of smoke from wildfires, of hurricanes and drought, they can very much disrupt any efforts to control COVID-19. And there have been studies looking at, for example, how to manage that in temporary shelters following hurricanes, and also thinking about how to maintain hand hygiene and access to safe water in drought conditions. So now I'm going to briefly speak to you about a study that we've been conducting with the multi-city, multi-country collaborative research network and the Centre for Mathematical Modelling of Infectious Diseases COVID-19 working group. So we collected COVID-19 data across over 500 cities in 26 countries from the start of the pandemic until May last year. And we used this data to calculate the effective reproduction number over a window of time for which local transmission had been established within each city in our study, but before government interventions had sufficiently intensified to reduce contacts, because we were trying to use this unique opportunity to try and unpick any weather signatures in this early transmission before the impact of government interventions disrupted this pattern too much. And we were also controlled for other important demographic factors such as age and also socioeconomic indicators. And we were interested in understanding how key meteorological variables, including temperature and humidity, may have impacted this transmission early on in the epidemic in each place. We were using multi-level meta-regression models to allow for nonlinear effects. So one of the limitations of some of the studies that came out early on was the way that the meteorological information had been used in the studies. Often an average of the climate conditions across a whole country was used, which is clearly not very useful. So here, this is just a visualization of this. On the left, we can see the United Kingdom, and the stars are representing the locations of the cities within the UK. And then we can see that the temperature, this is the temperature across a single day, has varied quite a lot across the country. And if you'd have taken a single average, that wouldn't really represent the variation between the different cities. The same in Brazil. The average, across the whole of Brazil is not very useful for understanding variation in transmission from the south of the country up to the Amazon, for example. So this map here is showing us the COVID-19 effective reproduction number against the temperature in each of the different cities. So the circles shaded with a sort of dark purple are showing us those places that had both a high temperature and a high RE, whereas those places in bright blue are showing the places with lower temperatures and high RE. And we can see we have quite a spread, particularly in Europe and the Americas. It's very difficult to detect a clear pattern. Here this is showing the variation sort of early in the pandemic between government interventions in different regions of the globe. We can see they ramped up pretty quickly in the East Asia and Pacific region, and to varying degrees across other regions. So we incorporated variations in these interventions in our model as well. And we also conducted a sensitivity analysis to try and find sort of an optimum level of government interventions and the number of days to include within our window. And we found this sort of optimum level to be to use the Oxford Government Index of 70 on a scale of 1 to 100, and a window of up to 20 days. So in each place, this window started and ended at a different point, but we were just trying to sort of isolate that time by which local transmission had been initiated, but before the government index was dominant. And we found a sort of weak, sort of modest association between mean temperature and the effective reproduction number. We found a peak in the effective reproduction number at around 10 degrees C, and this dropped off quite quickly as the temperatures increased to 20 degrees, for example. Whereas even before the interventions were intensified to sort of extreme lockdown measures, these sort of early interventions, as well as sort of personal choices to take personal protection measures, this had a much stronger association and explained 6 times more of the variation than the meteorological factors. So this was interesting study to us to show that even though we tried to sort of control for the restrictive government interventions, they still explained a lot more of the variation early on in the pandemic. And going forward, it's going to be really important to also take into consideration the importance of new variants of concern, and also vaccination coverage, which will also complicate the way that we try and understand the impact of weather on COVID-19. So in summary, it's too early to factor weather conditions into decisions related to relaxing interventions, but the general consensus is that COVID-19 does have the potential to exhibit a seasonal pattern once the disease becomes endemic. and future studies need to consider not just the government interventions and socioeconomic differences, but also the variance in the vaccination coverage. So thanks very much for your attention. I'll be happy to take any questions.
Thanks so much, Rachel, for that very interesting talk. While the questions are coming in from the audience, I'd like to start with a question which relates to the work that you were doing trying to identify the signal from the meteorological variables in these few months before the real government intervention started. Do you have any sort of thoughts on how long of a time series you need to be able to look at the influence of meteorology? You know, in air pollution, for example, one of the critiques of the time series studies that have come out is that they have quite short times. The time series is not very long, so it's much harder to disentangle the role of air pollution from seasonality or other time trends that are going on with a short time series. Is that also an issue when your exposure of interest is the meteorology?
Yeah, that's very much, we do have the same issue. In this particular study, we were trying to, this is actually a sort of a spatial ecological study. So we tried to summarize this, the transmission over this early window in each place. We were using the effective reproduction number that's actually modeling the sort of the time of infection rather than the observed data. So we're using an approach that also takes into consideration things like reporting delays in the incubation period. And then we also sort of averaged the meteorological conditions over that same time period, bearing in mind that the lag between them would be shorter because we're capturing that infection period. But yes, it's important for the time series studies, of course, to be capturing things like seasonality, where you are in the year. We are sort of furthering these studies now using time series data with the later cases. It also makes it very complicated to pick apart how those government interventions are evolving, and you know, the compliance to those interventions is difficult to capture as well. There are some other sources of information that can help you to do that, things like Google mobility trends and other things. But I think for both the air pollution studies and the meteorological studies, it is very challenging with such short time period to really pick apart those seasonal signals.
Thank you. So we have a few questions coming in. One is about whether there has been any research on the influence of rainfall or precipitation on COVID outcomes.
Yeah, I mean, it has been looked at in some study. We did test it in our study as well. We didn't find any particular association. Of course, precipitation could, you know, potentially have a role in impacting human behavior and the way that people gather indoors, but I haven't seen any sort of evidence linking precipitation to COVID transmission so far.
There's another question here in the chat about Brazil. So does the pattern of having many cases of COVID in northern Brazil, so this is an area with high average temperature and humidity, does this say something about the adaptability of viruses or the new strains? I think
the reason it's been spreading so efficiently through places like Brazil is really just the lack of government control. It's just been allowed to get out of control, which means it's been able to spread extremely quickly, and has allowed things like you know, mutations and variants of concern to develop. So I think it's very much linked to the lack of coordination and control across Brazil that's allowed it to spread so efficiently across any weather conditions.
And here's another question, which is about the work that you mentioned, which you were investigating the period before the government intervention. So why, if you know, so why would you need to include the government index as a covariate?
That's a really good question, and we were actually surprised about how important it was. So we used a threshold. So if you're familiar with the government index, it ranges from 0 to 100, with 100 being, you know, the strictest interventions. And we chose a threshold of around 70, but we found that even using that cutoff, if you like, of 70, the variation in stringency of the interventions between 0 and 70 still was very important for explaining some of that, the variation in transmission between different places. So even the sort of less stringent non-pharmaceutical interventions were more important, if you like, than the meteorological factors in explaining that variation between the different cities.
And this is, maybe you can read the comment here, but the question was about the outcome, and was it the mean RT over a specific time window?
Yeah, so we're calculating the effective reproduction number over this particular window. So that window ranged from, I think we said the minimum window could be 10 to 20 days, and we had some lower limits as well. There had to be at least 10 cases had been reported within 10 days of the first report. So we had these sort of like lower and upper limits for defining our window. It was just a way for us to try and, you know, get the closest we could to this unmitigated transmission, although even the early government interventions were important in explaining that variation.
So are there any other questions for Rachel? It's a nice sort of horizon scoping question about what would your vision of an early warning system related to weather and infectious disease look like?
Thanks for that question. Yeah, so we've been doing a fair bit of work trying to link meteorological and climate information to early warnings of mosquito-transmitted diseases, particularly arbovirosis in Latin America and the Caribbean region. So we're looking at using things like forecasts of temperature and precipitation from 1 to 6 months in advance, to try and understand the spatio-temporal variation in different climate-sensitive diseases. So if we take the example of dengue fever, and we incorporate this information into predictive models to try and predict the probability of exceeding predefined outbreaks of these diseases. So thresholds that are relevant to the decision making in each place. So we've worked with the Ministry of Health in Brazil to develop early warnings for dengue in Brazil. We're currently working in Barbados to produce dengue predictions with a 3-month lead time, looking at things like drought indicators and temperature. We also have a system that's operational in Vietnam at the moment. In terms of COVID-19, I think that if and when COVID becomes sort of endemic and established, then meteorological information might help us to be able to inform, for example, national health services of potential increase in emergency service demand if we're to see particularly dry and cold periods. That certainly can be used for other respiratory viruses. So it very much depends on the sort of the strength of the evidence and the association linking meteorological factors to the disease outcome of interest, and then tailoring the climate information to suit the needs of the climate services to make sure that information can help guide preventative action.
Is it known why some respiratory infections display seasonality while others do not? And what is there a sort of predictable pattern there?
Yeah, there's been a fair bit of research into the seasonality of things like influenza and other human coronaviruses. So there's been laboratory work, establishing links between virus stability and cold temperatures and humidity. And it's very much thought to be linked to a combination of both virus survival, but also things like the school calendar. So you tend to see influenza outbreaks peaking when the kids are back in school in sort of autumn, winter, particularly in temperate regions. But you also have outbreaks of influenza in the summer in the tropics. So it's very much it's a very sort of the mechanisms aren't entirely clear. There's a lot of research into this area, but it's still not entirely clear why we see these different patterns.
So if there aren't any more questions, I would suggest we take a break here and come back in 10 minutes. And just to thank you, Rachel, for a terrific talk and these very insightful responses to the questions. And we'll see everyone back in 10 minutes, and we'll continue on with the program.
Thanks a lot.
And just to remind people that if you have a follow-up question, you can post it in the Slack channel and can carry on the discussion there. So I'll get started in just a minute here. Can you see my slides?
Yes, that's perfect.
Okay, great. So I'll go ahead and get started. Welcome back, everyone. I think you've heard me introduce myself in the first session, so I will dive straight into my presentation, which will cover the following points. Why should we be worrying about air pollution? And what are some of the hypothesized links between air pollution exposure and COVID-19? What are some of the methodological challenges in conducting epidemiological studies relating air pollution to COVID? And summarize what we know so far about the role of ambient air pollution in COVID-19, and also comment on how the COVID pandemic is potentially impacting exposure to household air pollution. And I will finish by just wrapping up. So, as I'm sure many of you in this audience fully appreciate, both ambient and household air pollution are drivers for a large amount of death and disability worldwide. That's illustrated quite clearly in this figure from the most recent Global Burden of Disease study, where you can see the disability adjusted life years on the x-axis. So ambient air pollution is responsible for about 5% of global DALYs. Household air pollution is responsible for a little bit less, about 3% of DALYs. And on the y-axis, we can see the annualized rate of change in these exposures between 2010 and 2019. So the good news is that there has been some progress in reducing exposure to household air pollution from solid fuels during this period of time. The bad news is that exposure to ambient particulate matter is increasing globally. But that global picture masks some interesting heterogeneity across countries according to level of socioeconomic development in global regions. If we look at high-income countries, for example, household air pollution doesn't appear as a major driver of DALYs. We see air pollution there, and ambient exposure to ambient particulate matter is decreasing in high-income countries, largely as a function of increasing air quality control. In lower middle-income countries, we see about ambient particulate matter and household air pollution are each account for about 5% of DALYs, and really quite striking differences in the time trends in these exposures. Whereas in low-income countries, we have an increase in ambient particulate matter. It still doesn't, is attributable to about, or 2% of DALYs are attributable to ambient particulate matter. So it's really a sort of emerging issue in many of these places. It's increasing and potentially in the future responsible for a larger percentage of the DALYs. But what we see for household air pollution is it's a whopping 8% of DALYs are attributable to household air pollution. It is decreasing over time, but a more modest decrease relative to what we see for lower middle income countries, which many of them have quite ambitious targeted policies in place to improve access to clean household fuels. So air pollution is a global public health crisis in its own right. And of course, now it's interacting with the COVID pandemic. So how might these two things be related? Several hypotheses have been put forward. One hypothesis is that exposure to air pollution can increase the risk of infection from SARS-CoV-2, that air pollution exposure can increase COVID severity, and that air pollution may play a role in the recovery after having COVID, so in COVID prognosis. There's also been quite a lot of interest in whether socioeconomic and demographic inequalities in air pollution exposure might explain some of the observed inequalities in COVID outcomes. Another hypothesis is that air pollution might be an effect modifier of public health control strategies, so that these control strategies might be less effective in places with high either ambient or household air pollution exposure. And there's quite clear biological plausibility for how air pollution might be linked to infection and severity. We heard about this last week from Tara's presentation, that there's available evidence to suggest that suppression of host defense to infection through things like reducing the degree of mucociliary clearance, suppression of phagocytosis by alveolar macrophages, increasing mucosal permeability, as well as upregulation of the ACE2 receptor, which is the receptor that the SARS-CoV-2 virus binds to. Air pollution might also be linked to COVID severity through its contribution to incidence of chronic diseases. So we have a large body of evidence linking long-term exposure to air pollution to incident chronic disease like diabetes and heart disease, which we know is associated with more severe COVID outcomes. However, there are a number of methodological challenges in conducting epidemiological studies to test these hypotheses, and some of those challenges are listed here. This includes the issue of having comparable case ascertainment over time and over space or across study areas. This is a challenge for COVID epidemiology in general, and studies focusing on air pollution are no exception. We know that there are important differences in how cases are identified over time and space, for example, between urban and rural areas. Also, there are important spatiotemporal trends in testing, so who gets tested and who gets identified as a case. And this is an important complexity for studies trying to look at COVID incidence. For example, we see from the UK Biobank population a clear relationship between the probability of testing and long-term air pollution exposure. So it's more likely for individuals in urban areas with high air pollution to get tested, for example, and this can be an important source of bias. In air pollution epidemiology, there's always quite a big concern with residual confounding. We're trying to isolate the effect of air pollution, which is generally a very small effect estimate. So that more general concern is compounded in the context of COVID, where we have to contend with the challenge of these very strong spatiotemporal dynamics of the epidemic, which are independent of air pollution, but are correlated with exposure. Or are independent of the effect of air pollution, I should say. And also, as Rachel alluded to, the public health interventions, which vary in space and time, can also be an important source of confounding in these studies. So in terms of fitting of epidemiological models, we have the issue of COVID outcomes being clustered in space and time. Much of air pollution epidemiology has focused on outcomes which we assume are independent. So this is something that needs to be accounted for in these studies. So just to elaborate on that a little bit, the top panel includes a figure of confirmed cases at the county level in Catalonia, Spain, at selected weeks in the first months of the pandemic. And what you can see is the stable pattern of cases the spatial pattern of cases is not stable. So quite marked differences from month to month. So you can imagine if you fit a correlation between the spatial distribution of cases and a surface of air pollution concentrations, you would get a very different association depending on which time period that you're taking the data from. The bottom panel is data covering the confirmed cases in Spain over the course of the pandemic. And I included this just to illustrate the point that there are very, very strong time trends in the cases. And this is, we have a multimodal curve here. And these strong time trends will be an important source of confounding in studies that are looking at temporal variation in exposure. So the methodological challenges that I just mentioned are quite general. There are a few additional considerations for studies looking at the influence of air pollution on the order of days to weeks. Typically, we study the health effects of short-term exposure using time series studies or case crossover studies. And as we discussed in Rachel's talk about meteorology, one of the complexities here is that we have relatively short time series for these COVID in the context of COVID. Many of the time series studies that have been published so far had data for just a few months, and this can make it very difficult to disentangle the influence between different time varying factors, for example, air pollution versus meteorology or season. The impact of public health control strategies is an important issue, which I'll expand on in a minute. And of course, in air pollution epidemiology, exposure measurement error is a big concern. That's also a particular concern in some of the time series studies that have been done in specific populations, for example, in hospitalized populations or populations in ICU, where there's quite likely to be a very low correlation between the ambient concentrations outdoors and what the individual in a building with very controlled mechanical ventilation would experience. So I've included a figure here, which I think is a nice illustration of some of the complexities of what happens with the introduction of these public health controls. So this is a time series taken from a study that used data from 63 cities in China in the first months of 2020. So you see this time series in dark blue. This is a mobility index, a daily mobility index, the MSI. There's a time series for PM10 in brown, as well as PM2.5 in this purple color. Before the outbreak started on about the 24th of January, you see there was a big increase in mobility, and this was an increase in mobility as people were moving around to celebrate this spring festival. The outbreak started, there were very stringent controls put in place, and you can see that the mobility decreased quite drastically. Not only did the mobility decrease, but also the PM levels decreased as well. And obviously the point of the control measures were to decrease cases, which it did do. But if you were to do a naive analysis of these data, you'd see a positive association between air pollution and cases in, let's say, a lag of about a week, really just because of the confounding influence of the control measure. So particularly at the beginning of the pandemic, a number of ecological studies were published, and this is understandable. These studies are relatively easy to do quickly, and much of the data that were available at the time were available at an aggregated level. It's important to consider some of the methodological issues with ecological studies. So one of the main issues is that what most of the hypotheses that we're interested in are what's going on at the individual level. Is an individual's risk of infection influenced by their exposure to air pollution? And of course, with ecological studies, we're fitting an association at an aggregate level and cannot make inference at the individual level. So as you can see here in this sort of classic image, if you look within a population with increasing exposure, you see decreased frequency of the outcome. Whereas if you look across populations, you see really the reverse association. Another issue with ecological studies is the challenge of the modifiable area unit problem. So many of these studies are using areas that of aggregation that are based on administrative areas, so perhaps counties, cities, provinces, and depending on what that level of aggregation is, you can get a different association. And this is really just an artifact of the how the aggregation is defined in space. Also, many studies were using in ecological studies, it's an area level analysis, and exposure is assessed at an aggregate level. So one measure of exposure for a given province, for example, or county, and we know that that's masking a lot of important variation in exposure that it exists at the individual level. That we know there's a lot of important variation within cities or even within a given road segment, for example. So there have been a number of studies that have been published so far, and now several reviews summarizing that literature. I'll just say a little bit about a few studies just to give you an idea of what some of these approaches have looked like. Here is an example of an ecological study that was published quite early on in the pandemic that was based on a county level analysis in the US. So this team used data on COVID deaths per million population through mid-June and looked at the association with county average PM2.5, adjusting for a number of county level factors as well as meteorology. And you see observed an association with the mortality rate of 1.14, a 1 microgram increase per meter cubed of PM2.5. A quite similar study was conducted by another team of researchers that used data through July. Here they looked at not just deaths per million population, but also case fatality rate, as well as some additional pollutants beyond PM2.5. But essentially a very similar study design. And here you can see the associations that were reported for NO2, for the case fatality rate, and the mortality rate. So those are some examples of the big ecological studies that were received a really large amount of media attention early on. We now are seeing more individual level studies, and certainly many more are in the pipeline. So just to summarize some of the individual level analyses that have been done in the UK Biobank population, there have been two analyses conducted that have looked at the association between long-term exposure and testing positive conditional on being tested. So if you remember in the first lecture, Neil Pierce talked about the test positive study design. That's what was used here. And this, I think, is a nice illustration of getting around some of the issues that you can see in the UK Biobank data, where just the probability of testing itself is associated with air pollution. So the first study was based on data through May, and the second study was based on data through April, so slightly different time periods, but you can see that they reported quite similar odds ratios for a 1 microgram per meter cubed of PM2.5, roughly. Another analysis in UK Biobank looked at the association between long-term exposure and COVID deaths using data through September of 2020. And you can see the number of deaths was about 459. So this is, the estimates from this study are not very precise, but you can see the odds ratios reported here for 1 standard deviation increase in exposure. Another individual level study that I wanted to mention looked at both the effect of long and short-term exposure to PM2.5 on COVID death in Mexico City. This was done by a team of econometricians, and this used data on deaths through October. The PM2.5 exposure data was averaged at the municipality level, and the daily data were taken from the nearest monitor. And in this publication, they report a positive association between long-term PM2.5 and the probability of COVID death among those who were previously diagnosed. And in models that included simultaneously long-term and short-term exposure, the effect estimates for long-term exposure were considerably larger than for short-term exposure, which was defined as the previous 14 days, which is quite consistent with what we've seen for other non-COVID outcomes. Not sure how well you can see this figure at the bottom, but this is a figure that is looking at the effect of long-term exposure on COVID according to age. So really looking at effect modification by age, which they see a stronger association in these older age groups. So these individual level studies are coming. I think we can expect many more to be reported in the next year or two, and really to really understand what is going on between air pollution and COVID. I think we want to see many more individual level studies, that particularly those using longitudinal data that have very clear outcome definition. And in some cases, this may mean disregarding data from the first wave in some countries where the outcome definition just was not very well standardized. Ideally with address level exposure linkage. The UK Biobank, for example, is a very select population. There are some limitations there in terms of external validity. So really, it will be important to have large individual level studies in the general population. And then, of course, very careful adjustment for confounding with some of these strong spatiotemporal dynamics of the epidemic, for example. So I will now move to household energy, household air pollution, and the Sustainable Development Goal 7 focuses on increasing access to affordable and clean energy. And unfortunately, there have been important big barriers for progress in achieving this goal due to the pandemic. So about 13 million additional people are expected to lack electricity in Africa in 2020 compared to 2019. As you can see in the figure, starting in about 2014, the number of people without access to electricity in Africa started to go down, which was quite good news, but you can see how it started to tick back up in 2020 due to the COVID pandemic. And this is for a number of reasons. Firstly, governments have shifted financial resources to the emergency response. There have been important operational and financial barriers to deploying clean energy solutions. There's been about a 10% drop in the sale of solar products in Africa in the first part of 2020 relative to 2019. And sadly, about 6% of people who had access to electricity were expected to not be able to afford basic electricity services as a consequence of the pandemic. And I think it's important to point out that about 28% of health facilities in sub-Saharan Africa have access to reliable electricity. So this is a big barrier for the pandemic response in these settings. So there are a number of ways in which COVID has potentially impacted exposure to household air pollution. Firstly, we've had mobility restrictions, which have increased the amount of time spent in the home, and in situations with very strong sources of indoor air pollution, this has led to an increase in personal exposure. We've seen a decrease in access to clean fuels due to supply disruption in both the production and transportation of fuels like liquid petroleum gas, decrease in affordability of clean fuels due to loss of wages, and in some settings, movement of people from urban centers to rural areas where the reliance on more polluting solid fuels is much more common. So these are all factors that could increase personal exposure to household air pollution and leading to impacts on health related to COVID, but also non-COVID health outcomes. So this is a very nice study that tried to disentangle the influence of migration, changes in ambient and indoor air pollution due to COVID in the Chinese population. So in this top panel, on the x-axis, you have the time between December 2019 and March. The study was divided time into these two periods, P1, which was before the pandemic, and P2. And you'll see basically this January 2025, there was this spring festival occurring in China. On the y-axis is the population weighted exposure to PM 2.5. So what happens with the Spring Festival is that you have a large number of people that are moving from urban areas back to their villages in rural areas. And what you can see here in this blue line is the population weighted exposure that was modeled to have actually happened during this period. If you had applied the same migration patterns as 2019, you would have seen this red line here. So you can see many more people were basically stuck in these rural areas because of the quarantine, and had this impacted their exposures through being in households that had more use of polluting solid fuels. So many more people in rural areas, increased energy demand in these rural households that were relying on solid fuels. So this study, if you look at the figure on the bottom, then went on to disentangle these different factors that were contributing to exposure. So there was a large decrease in the ambient exposure, so about 16 ambient concentrations, about a 16 microgram per meter cube decrease in outdoor air pollution, an increase in indoor air pollution due to increased time spent indoors, but also this influence of migration. And if taking this all together, overall, there was about a 6 microgram per meter cube increase in population weighted PM 2.5 exposure due to COVID, accounting for all of these factors together. This is a publication that was published as a preprint very early on in the pandemic, and I think is another illustration of the potential for sort of backsliding from clean to more polluting fuels as a consequence of the COVID pandemic. So this was a pre-post study that was done in an informal settlement in Nairobi. About 95% of participants reported an important loss of income following the beginning of the pandemic, and about 25% reported of people who had been using LPG reported shifting to more polluting fuels for household energy. So just to wrap up, there are good reasons to believe air pollution is relevant, but it's in terms of COVID outcomes, but it's very challenging to study for a number of methodological reasons. We have now many ecological studies that have explored this, the relationship between between ambient air pollution and COVID outcomes, but they're very difficult to interpret for the reasons that, that I mentioned. We're starting to see individual level studies. Large individual level studies are underway, and I think we'll have a much clearer idea of what the role of air pollution is in the next year or two. So, you know, it does take time for this type of research, and you know, it's becoming clear that COVID-19 has really presented some important barriers to progress towards clean energy access, that there is a role for targeted policies to protect vulnerable consumers, for example, from backsliding to more polluting fuels, but you know, it is having an important impact. You will have access to the slides. Here are the references to the papers that I've mentioned, and I will stop there and would be happy to take any questions. I can't see the chat. So I'm going to stop sharing my slides so I can see the chat. For the proposed mechanisms, I was talking about short-term or long-term air pollution exposure. It's the concern about air pollution contributing to chronic diseases and chronic diseases mediating the relationship between air pollution and COVID severity is quite specific to long-term exposure. For some of the other mechanisms, I think they would be relevant for exposures over a range of different averaging times. So, for example, impacts on mucociliary clearance and things like this. I think it's you know, obviously longer term exposure is likely to have a larger impact for some of these things, but there may very well be an observable impact for shorter term exposures for some of the mechanisms as well. I should say a lot of, you know, it's interesting to look at the smoking literature, which is a sort of useful analogy, and you see many of the same sort of mechanisms among smokers, and there it's a very long-term sort of prolonged exposure that, you know, has clear impacts on mucociliary clearance and things like this. So any other questions? So how can variants impact the effect of air pollution on COVID? So that's an interesting question. And I think that, you know, Rachel alluded to this in her presentation, which is, you know, I think it's another source of complexity in doing these kinds of studies where we, you know, the spread, we have this spatiotemporal trends in the, let's say, COVID infections in general, but you can imagine you have these sort of different trends for the different variants in space and time, where the variants are playing a role in shaping those spatiotemporal patterns. And, you know, I think what Neil alluded to in the first set of lectures is, you know, how we're sort of in the dark to some extent because we don't have a good idea of who is infected. And this is even more the case when we're talking about variants. We don't know who's infected by which variants. So I would say it's interesting and going to be an additional source of challenge, and we can try and get around that by looking at different time slices. So, for example, restricting the study period to a period before the introduction of a major new variant. What are the policy implications surrounding the influence of air pollution on COVID? Yeah, so I think, I mean, the way I see it is, what are the policy implications of the influence of COVID on clean fuel access? And there, I think, there have been some attempts to basically protect vulnerable consumers from sliding back basically to more polluting fuels. So things like cash transfers, for example, is one policy option to help people basically maintain the use of clean fuels, providing additional cylinders of LPG, for example, so to basically buffer some of these issues around the challenges in the supply from COVID. So and another policy option is to really try and prioritize health centers and first responders, so that these health clinics and people who are instrumental in the response to COVID have more reliable access to clean energy. So I think there are some clear recommendations and that have come out of this, and it's some very nice experimentation of different policy options in places like India, for example. How do you see the role of ecological studies in supplementing the individual level studies? So I think we have a lot of ecological studies. I should say they're not all created equal. Some of them are quite well conducted, and there are others that are just essentially correlation studies and have been done not using standard epidemiological study designs. I think that would be my first point. But if you look at the very well-conducted ecological studies, and now we're seeing some that are done at very small, let's say, neighborhood scale, which some of the issues around confounding are probably less of a concern there, but you still are, will just inherently can't make inference about individual level associations. So I think they, it can be, we have the hypotheses. I don't think we needed them for hypothesis generation. I think the hypotheses came out straight away, basically. But I think they have really pushed the conversation forward in terms of really refining what kinds of studies do we really want to prioritize going forward to try and get a better understanding of what the role of air pollution is in COVID. So SES as a confounder, yes, definitely SES is an important confounder both at the individual level, but also area level in in individual level studies looking at spatial variation in air pollution and non-COVID outcomes. There's we know it'll be important for COVID as well, based on what we know about who gets infected as well as who ends up with severe COVID given infection. A very difficult, it can be quite difficult to measure well, particularly in these kinds of large administrative studies where we don't have individual level so much detailed data on individual level SES. But I think you can do a lot with very good area level adjustment for socioeconomic position. And we've done quite a lot of work in London, for example, looking at after adjustment using small area level measures of deprivation, how strong is the remaining confounding from individual level SES, and it was really quite small because the correlation between the spatially distributed air pollution and area level SES is much stronger than with individual level SES. So it's important. I think it will be interesting to really dive in and explore this in detail with the data sets that are available to researchers working on this. And obviously, it's not just an issue for confounding, but there's a lot of interest in effect modification. Is the effect of air pollution the same for everyone? And basically, we see such strong inequalities in the various COVID outcomes that it's an important topic to really understand well how air pollution might be contributing to that. So any more questions about air pollution? If not, you can shoot me a question on the Slack channel, and we can now move on to the final talk for the day, which is from Alistair Woodward, who is in New Zealand and hopefully asleep right now, but we will move from thereby.
Hello everyone, I'm Alistair Woodward. I'm from the University of Auckland in New Zealand. I'm delighted to be contributing to this short course. I'm recording the talk because the timing doesn't work quite so well for us in this corner of the world. Let me share my screen so we can get started. Right, so I'm going to talk about transport systems and public spaces. Both of them are important for COVID-19, but why talk about them together? Well, really because they're co-located, that's my logic. In cities, for example, streets make up maybe 80% of the public realm, and of course streets are the home of land transport systems. In ordinary times, in fact, the streets are absolutely dominated by land transport, and it's only in extraordinary times like the COVID pandemic that we appreciate that, maybe fully appreciate that the streets could have other uses. That's the point of my photograph on the right-hand side of this slide, and I'm going to talk a little bit about the life in a low traffic neighborhood study shortly. But here's what lies ahead. I'm going to try and cover these points. We've only got 25 minutes. I want to talk about some features of the COVID outbreak that are particularly important, I believe, for transport and public spaces. I'm going to attempt to answer very quickly why it is that that streets matter. I'm going to talk about both theory and practice of changes in streets for pandemic response and recovery, the question of how transport systems affect disease risk. I want to talk about that as well, and then just at the end a slide to quickly wrap up. Well, the first point about COVID, and it's a really important one for us, is that this is a problem that's not going away in a hurry. Jacinda Ardern, our Prime Minister, used this expression, it's not a sprint, right at the beginning of the outbreak, and I think this still holds true. The graph comes from a paper in Science, one of the very first to try and project what might lie ahead. It was wildly optimistic. As you can see, 2021 was supposed to be a quiet year. But I think the general conclusion of the paper that we should expect there to be virus activity for, the medium-term future really still holds. Even with the arrival of vaccines, there are obviously considerable uncertainties about the duration of effect and the effectiveness of viruses given the viral lability. The other point about this question, of course, of what lies ahead is that maybe COVID is a sign of things to come. And Peter Doherty, who's an Australian immunologist, is arguing that the combination of global connectivity and unprecedented ecosystem pressure means that this is really the beginning, the beginning of a pandemic age. COVID's just a trial run. Well, whether you agree with Peter Doherty or not, a slightly gloomy prognosis, I think the important point is that hygiene measures are going to be a public health priority for some time to come. And hygiene in terms of pandemics, really the intervention that is most powerful is physical distancing. This is because it can be achieved by environmental change. It's scalable, whether you're talking about neighborhoods, cities, or whole countries. And also it's more reliable, perhaps, than measures that, like masking and hand washing, that rely on individual decisions in every case. This is another point about the about the COVID epidemic that is terribly important for this particular talk, and that is that in almost every circumstance, outdoor activity is safer than indoor activity. This comes from a publication in the British Medical Journal last year. It's an attempt to provide a decision guide. It's not precise, but it is looking at an assessment of the risk of transmission by location for different activities. And you can see for almost any activity, the risk of transmission is much higher indoors than outdoors. Well, part two of my talk, why streets and other public spaces matter. First of all, look at the picture on the left-hand side of the slide. This is a painting by Pissarro. It says two things to me. One is that, we have a long history of pandemics in cities. Haussmann, who was Napoleon III's architect and was given the job of rebuilding and cleansing Paris, was working in the midst of the third cholera pandemic that ran through the 1840s and 1850s. And the second point for me of the painting is a reminder that the relationship between plagues and places is bidirectional. In other words, the qualities of place certainly make a difference to the risk of infection, but our response to infections can have a profound effect on the kinds of environments that we live in. And that, of course, was the case in Paris once Haussmann had completed his work. Why do streets matter? Well, the obvious point that it's where lots of people gather, 80% of the public realm in big cities, remember, and therefore there is plenty of opportunity for pathogens to spread. Rapid change can be made because we can change their physical environment. It's rebuilding cities. Rapid? Maybe not, but it certainly can happen reasonably speedily. And then the third point that I want to emphasize is that if these changes are made thoughtfully, then there are many co-benefits, potentially co-benefits, that can be achieved. I mentioned to you this study earlier on, the life in a low traffic neighborhood. So this was a study of people's experiences in low traffic neighborhoods in New Zealand during COVID lockdown in the first half of 2020. It's not an epidemiological study, but it, I think, has some rich material about the direct and indirect effects of a COVID response. No doubt the restrictions in mobility reduced the spread of infection, but these other benefits that are listed on the right-hand side were also achieved. And just to give you an example, here's a quote from one of the participants in the study, reflecting on the new social connections that arose in neighborhoods that had, for a while, very little motor vehicle traffic. Here's the quote: "Despite having to maintain a physical distance, the fact that there's such a huge reduction in noise from cars means that it is much easier to have a conversation with neighbours. I talk to people much more when I'm out on walks. The noise thing came up a great deal, and obviously the effect on interactions is particularly marked amongst older people whose hearing is impaired. The effects worldwide are shown in this slide here, just as a reminder that there were profound effects in the first half of the year in many countries on mobility patterns. Motor vehicle traffic was reduced, although in many places there was followed by a rebound, as you can see in this graph. And there were changes that were less desirable from a public health point of view as well, such as a sustained reduction globally in terms of people's visits and use of parks. The drop in motor vehicle traffic translated into improvements in air quality. This is an attempt to get a global picture of what happened using NO2 ground station measures. And you can see from the graph that, from the map, that in many places, most places, there were substantial improvements. And indeed, compared with 3-year averages up until 2020, there was a marked reduction in NO2 exposures. Notice also from this map that the Pacific has vanished. It's all right, it happens all the time. I'm not offended. Well, what changes can be made to streets to reduce infection risk and maximize co-benefits? Firstly, talking about the theory of it, there are some great design guides, and this is one of the best, I believe, produced from the US by the National Association of City Transport Officials. It's a good one to look out for, and just as 3 examples of the kinds of changes that can be made, simple things like increasing width for walking at say appropriate physical distances. You can see that that idea of building out the footpaths to give people opportunity to pass others safely without having to step onto the road. The safe queuing zones, safe access to public transport. In almost everywhere, public transport's continued to play a vital role. For example, in ensuring that essential workers can get to where they need to go. And it's a simple thing to do, but it makes a big difference to the comfort and safety of using PT to give people room where they need to wait. It's obviously desirable that people in pandemic times spend time outdoors and have the opportunity to exercise, and to do that safely. It's been commonly observed that although motor vehicle traffic was reduced under COVID, speeds tended to creep up, and the variability, the spread of speeds also increased. And we know that both of those things are important risk factors for injury. So more important than ever to provide space, safe space for active transport, and that means pop-up bike lanes, it means extended footpaths, it means protection, both with markings and maybe hard protection as well, one form or another, for pedestrians and cyclists. That's the theory. What about the practice? Well, just as an example, this is a study that we've just published on New Zealand's response to COVID-19. I should say 2 things about the New Zealand context to help, so you can help understand perhaps what I'm about to tell you. One is that New Zealand has an extraordinarily car-dominated transport system. About 85%, I think, of transport of mode share as private motor vehicles. And secondly, that at least so far, fingers crossed, New Zealand has been very lightly touched by COVID. Our COVID mortality is about 5 per million. And I think that compares with 1,500 per million in many other countries in North America and Europe. What happened in New Zealand was that there was support in principle for including transport in the pandemic response, but the authorities were often pretty hazy about exactly what they were doing and what the reasons were for making street changes. Considerable hesitancy in acting in the face of predictable pushback from people who were concerned about car parking, for example, and reduced motor vehicle traffic. and the interventions were, as typical in transport systems, were typically demand-led. So the top picture here shows a pop-up bike lane, and the fact that it was seldom used was taken as evidence that it was not needed, and it was removed quite promptly. Now, you might look at that picture and think of other reasons why people were choosing not to cycle in this lane, quite apart from the need for such a facility. Two other points that became particularly apparent to us when we looked at how other places had responded compared with New Zealand was that the regulations and frameworks which enable transport agencies to make changes are terribly important and are not always fit for purpose. And secondly, that it's much easier to move quickly if there is already a plan to hand. Both points were made very well, I think, in the London example. You can see the slide at the bottom from London, the picture at the bottom from London. London was one of the fast movers, and that was partly because they had been working on a street space reallocation program for 5 years, and the arrival of COVID was sort of fortuitous and enabled them to move quite quickly to put the street space program into operation. and secondly, they were able to do this, empowered to do this with two statutes, one being emergency powers, and secondly, the experimental street changes enabler that applies in the British system, neither of which we had access to really in New Zealand. And that was one reason why I think the New Zealand response was so slow and so clumsy. Well, transport systems and disease risk. I said this would be the fourth of my 5 parts to this talk. There are 3 things I want to say really. One is that I think there's good evidence that travel restrictions do reduce the spread of COVID-19. There is good evidence also that mode of travel is important in terms of risk. And thirdly, there are some risk factors that come through, particularly, I believe, confinement and duration of travel, and also perhaps proximity, but to a lesser extent. So let me explain. First of all, the travel restriction story. Whether or not travel restrictions were effective, was sort of up in the air. Before COVID, and WHO did not recommend restrictions on the basis of experience with other pandemics, but there is reasonable evidence from COVID that have made a difference. This is a paper that looked at the effects, or explored the effects of the quarantine of Wuhan. At late January 2020, there was an abrupt and severe restriction on flights out of Wuhan. What would have happened without that travel ban? Well, probably the effect on viral spread within China would have been relatively minor, but a much stronger effect on the export of COVID cases internationally. The reason being that the virus was already pretty well seeded in mainland China when the flight ban was brought in, but not so prevalent in the rest of the world. Continuing the planes story, this is a paper that's been a very interesting paper written on in-flight transmission. It's quite hard actually to disentangle all the possible explanations for in-flight for COVID transmission or potential COVID transmission on planes. This is a study of a particular flight to New Zealand, Emirates Flight 448, from Dubai to Auckland. Just to give you some idea of the background here, in New Zealand, all international passengers' arrivals are quarantined and are tested regularly for COVID in quarantine. Following the arrival of this flight, there were 7 passengers out of the 86 on board who tested positive for COVID. Important to understand that while the flight had come from Dubai, most of the passengers had come to Dubai from many other places. So there were 5 passenger origins amongst the 7. For what it's worth, 5 of the passengers had negative tests pre-departure. Each of the coloured circles in this slide is a passenger, and there are 2 pairs where it's believed that there was spread from one to another, unrelated to the flight, either immediately before or immediately after. But there were 4 passengers where it does really seem to be the case that this was transmission on board, partly as a consequence of the timing, partly as a consequence of where people were sitting and so on. But the major point was the fact that the genomes of the virus in all 7 cases was identical. So here's an interesting addition to the epidemiological toolkit, sort of fingerprint test. The genomes were the same, and really interestingly and importantly, there was a match with samples in the country of origin of the patient, so-called patient A, who was believed to be the index case. Identical genome to that discovered in sampling in the week before flight departure. So powerful evidence that it is possible for the virus to be transmitted on board planes. I don't have a bus, I don't have a train slide, but I do have a bus slide. And this is from a study in Eastern China, a very good study, I believe, the way it was done, the quality of the evidence and so on. You can see this was a full bus trip for about 100 minutes. The index patient was halfway down on the left. The cases that arose as a consequence of the trip are the pale red colours. And the interesting thing, one of the interesting things about the study is that the distribution of the cases, there wasn't a tight cluster of cases around the index patient. They were spread right across the bus, suggesting that the mode of spread may have been airborne transmission rather than direct spread. Automobiles, planes, trains, and automobiles. This is a photograph of a billboard that was erected in Auckland during COVID lockdown last year by Wilson Parking. It's a company that runs parking stations. Now, this comes up in the multiple choice questions that you're going to be doing later. But just to introduce it really, I think the message in this billboard, raises three questions, at least three questions. Is driving truly a good way of staying safe? If you think about the risk over the whole journey, what would be the consequences of shifting trips from PT to private vehicles, as Wilson parking was encouraging? And thirdly, this is an interesting point, I think. In New Zealand, the stay local message was a really important one, was thought to be a really important one, urging people to not move around the city, but to stay in their areas. And what would be the consequences? Or firstly, why is that important? And secondly, what would be the consequences of a surge in the use of private vehicles in pandemic times? I suggest you give some thought to those things. Well, walking didn't get a mention in the Steve Martin film, but it's obviously an important point, an important mode of transport. I think it's seldom been identified as a cause of outbreaks of infection, walking, although people have been quite concerned about it as a possible source of infection. It doesn't appear to commonly be that way, but there's good reason to believe that open spaces are likely to be safer than confined ones. So another reason for providing good space for people to walk outdoors. This is a study of air currents, modeling of air currents, and the spread of viral particles associated with breathing and coughing. I've come to the end, and this is my wrap-up slide. Three things. I think it's undoubtedly the case that transport systems can be a cause of infection, and we know a bit now about what the features of transport systems are that might be important in terms of promoting infection. We also know that changes to transport can play a part in terms of pandemic control and recovery, both in theory and in practice. We now have evidence to draw on. And then thirdly, the co-benefit point that if these changes in transport and the public realm are made thoughtfully, then there's a host of gains that can be made. Physical activity, nature contact, clean air, social opportunities, all those things are worthwhile, and perhaps particularly worthwhile during pandemic times, such as those that we've gone through with COVID-19. I'm going to stop there, and I look forward to the discussion.
Well, thanks very much for that really interesting presentation, Alistair. And I know that the role of transport mode and public space in COVID transmission has been a really hot topic of much interest in Barcelona. And I'm sure it's been very much in the sort of media and public discussions in urban areas around the world. So firstly, I'd like to ask about COVID-19 transport and health. If you could really pull out for us the key takeaways on that topic from your presentation.
Yeah, sure. I think of three things. One is that transport systems definitely can be vectors for the transmission of COVID-19 and other infections of similar kind, as you mentioned. There's no doubt about that. They can contribute significantly to the spread of pandemics. But the same systems can also be levers of control, that there are opportunities. Maybe we can talk a bit more about this later, to quite spectacularly break transmission in a relatively effective way. And then the third point that I think is important to bear in mind is that there really is an opportunity if we respond thoughtfully, I believe, to achieve other health gains apart from pandemic control through changes to transport systems and public places.
So that sort of alludes to this concept of the co-benefits, which you touched on in your lecture. I'm wondering if you could expand on this concept of co-benefits and what we learned from the COVID experience a bit more. Are these specifically co-benefits of less travel overall, or specifically shifts in travel mode share? And are these health co-benefits or environmental co-benefits, or are we talking about both? And really behind this question, it strikes me that there are a number of trade-offs from, let's say, reduced travel overall, that there are potential health benefits, which you mentioned in your talk, but also negative impacts of maybe increased isolation, increased sedentary behavior, and how, as researchers, do we think about getting a handle on this overall impacts, both positive and negative, to really glean insights on how to promote the positives and minimize the harm?
I think we tend to use co-benefits as sort of shorthand for lots of incidental outcomes, and you're quite right, of course, they can be negative as well as positive, and they can apply to the environment as well as to human health. I think they also are quite contextual, and you mentioned the situation in Barcelona, which is just so different to the situation here in New Zealand. In terms of the severity of infection and the duration of lockdown, and so perhaps the balance of positive and negative outcomes is a little bit different. Here in New Zealand, where the epidemic has been relatively mild, and the period of severe restrictions on activity was quite brief, I think the balance of outcomes was pretty strongly in the positive direction. There certainly was, for some people, a period of isolation. So I think you're quite right that there's an important equity element here. I think that for some people who had spacious houses and stable incomes and so on, and peaceful family arrangements, it wasn't necessarily a bad thing to have to stay at home. But for others whose situations were more difficult and more demanding, it was very stressful. And so that's a point. The point about the amount of travel, it's an interesting one. To what extent were there negative health consequences as a result of people being restricted in the amount they could travel? I'm not sure that we've got a good handle on that at the moment. Certainly concern about the effects on healthcare, people not being able to access healthcare as readily as they could in the past. The mental health consequences are something that people are very concerned about. It's rather interesting that there was just recently a paper in one of the Lancet journals looking at suicide trends last year, and somewhat to people's surprise, the outcome seems to have been a decline in suicide, in most countries. So it's an area that we don't have, full understanding of, I think. What is the balance of positive and negatives? Who's most affected? Who do we need to look out for, particularly if we're wanting to use the COVID opportunity to improve health for all? Still, a lot of the story we don't fully understand yet. That's my impression.
Yeah, no, it's very interesting. And it's also, I think, interesting to think about, whether there are insights that can be gleaned from the COVID experience about the sort of sweet spot in terms of the amount of travel. What's desirable for society, and can we prioritize certain types of trips or travel and replace other types which are, less value in some way to the individual or to society. We've seen such a flourishing of technological alternatives to travel in terms of virtual tourism and conferences and things like this. So it's interesting to think about how we might prioritize travel in the future post-COVID. So my next question is about research gaps. You just alluded to many of the things that we don't fully understand at this point. What do you see as the most important questions that really pop out as important research gaps in this area?
Well, I think that although we have obviously some information about infection and mode of travel, I think we know enough yet, to be absolutely certain about the kinds of policies we should be promulgating. The whole future of public transport in a virus-strewn age. Just what are the risks associated with public transport? To what extent can they be mitigated? What are the aspects of public transport that are most hazardous? I think those sorts of questions are really important. I think infection associated with use of private vehicles, of refuge, and at least in some parts of the world, including New Zealand, there's been a tendency to encourage people to, retreat to the private car. Now, is that really a good thing to do? I mean, is it a good thing to do for other reasons in terms of, pollution and public health? But even in terms narrowly of COVID, is the private car the right place to be? Given what we know about the risks of indoor spaces, would it be better to think of other ways of supporting travel around the city in times of virus threat? So I think those are all important questions. We started talking about the effects of restricting mobility. I think there's big research questions there, aren't there, about the effectiveness of quarantine, about the effectiveness of, tight borders versus loose borders, about stay-at-home orders, stay local provisions. If you look around the world, I believe we've seen a great variety of policies in response to COVID, and it'd be nice to know what the consequences are. What is the right mix? You talked about a sweet spot. What is the sweet spot in terms of restricting movement to do as well as possible on back the virus, to do as least damage as possible to other aspects of people's lives. This is very much on our minds at the moment here in New Zealand, because today we opened up our borders for the first time in 15 months, and there is now free travel between Australia and New Zealand, which people are excited about and awfully nervous about at the same time.
So there's a lot of work to do. It will be very fascinating to see what researchers can shed light on in the coming years. So the next question relates to some of the positive changes that you mentioned in your talk. For example, the increases in cycling and active transport. Are these and changes in infrastructure to support active transport, are these sustainable? And what can public health professionals do to support the shifts that happened in COVID to make them more durable, durable changes post-COVID.
Well, when I think about what we as public health professionals can do at times like this, I sort of think of ourselves partly as citizens, so the question is, what can we do as individuals to support positive social change, and partly perhaps, as professionals with special expertise and knowledge and skills. And it's a bit the same as the question about, climate change. What can public health do about climate change, such a huge issue? I like the advice that I was given by a professor of psychology who said, in terms of acting effectively as citizens, you should model, you should speak out, and you should vote. Meaning, that if you believe certain actions are worthwhile, then at least, you should show that you believe they're worthwhile in terms of your own behavior. That speaking about things is terribly important to ensure that it remains a live issue. And many of these things have a political element to them, and ultimately it's it's the action of government that matters so much. And I think if we think about this, how do we make the positive changes sticky or sustainable? There is a radical edge to this. If we're really talking about trying to change the transport system, which I think is what we need to do. I think, tinkering is not going to make a big difference, really. We'll return very quickly to the pre-COVID arrangements. Then it needs to be thought of in that, at that big level of what are the interests involved? How do we bring about social change? So that's the big challenge. But as professionals, I do think we have an important role as sort of knowledge brokers and communicators. I mean, don't know what it's like in Spain, but certainly, in New Zealand even, there's been plenty of misinformation flying around, lots of doubt raised about many aspects of COVID. And I think we have a responsibility in public health, as public health scientists, really, to understand what's happening, to communicate what we find, and to contribute to public debate.
That's great, and I would think a perfect place to close this question and answer session. And thanks so much, Alistair, for this very fascinating presentation and your insights on these topics. And just to say, if people have additional questions for Alistair, you can ask him directly in the Slack channel for transport, and you can have keep the discussion going there. So thanks again, Alistair, and we'll move to the next speaker. So hello, everyone. Because we did change the order today, there is no next speaker. So that is our final lecture for the day. And you have a learning activity in Moodle covering the material today. And Ariadna, how long will the learning activity be open?
It will be open until Sunday midnight. ST time, yes.
Okay, so please do go to Moodle and complete that activity, and we will see you back here on Thursday for the final session. Thanks very much, and thank you very much for all of the speakers, and it was really a great sort of span of topics there that we covered today. So see you on Thursday. Goodbye.